You're going to do the install here.
How do I, yeah. It's not popping up as a... thank you. No, though?
No. Is someone only have?
2 seconds.
I'm going to tweet a photo of how many Harvard grads does it take to put up a poster?
これ反応しない全然こうパソコンから見えないんでどの穴刺しても多分 Mac で作ったんだと思うんですけどこれに Oh, this one. Okay.
Thank you. Okay.
Oh, you do? Yeah. Do we have an extra spoon? Oh, you have an extra spoon. Let's use an ask. So you might have to, here it is. The half, no, no, see at the metal part? Yeah. Take it apart like this, so you can fold it.
Wait until it's over.
Because they should be parallel.
When are you completed?
It's always.
Hi. Oh, no, not.
Where are you now? I'm from Martin. Sorry, I'm Martin. Saitama Children's Medical Center. That's very near. So there's actually my boss was trained in Boston Children's Hospital. Yeah. But also he has
Here you go.
Hi.
surgeon or the anesthesia in developing countries.
Okay. So,
This one?
those are the slides, and there are two videos on here.
This one, this one?
Yes, that one and that one. And then let's see, it's already.
あ、こちらで、ちょっと呼んでた方がいます。
I don't think so.
Table
I think just the chairs.
You need a table?
A table would be nice.
Yeah, it would be nice. Yeah. And then
This
that
one,
one as well.
okay.
And then it's probably too late for these, but that folder has videos in it, just to do before. Oh, maybe
It's heavy.
cancel that. Cancel that one.
Yeah, it's gonna be.
Okay, and these two videos are played within the program, and then those are just the bio slides.
Can you do that?
Yeah. Okay, let me go get a program really quickly so I know when to play them.
Harry, yep, it needs to fit down here.
Hello, everyone.
佐藤さん、ここってあれですよね。ここは音声つないじゃダメなやつですよね。使う。Are you going to operate?
Yeah. Can I test them really quickly?
Yeah,
before we
sure.
put it back up?
Double click. And this is the volume.
Okay.
Oh, yeah, sure.
Thank you.
ちょっとテーブル出します。すいません。
今のところチェックをしてもらってます。Okay, one more check.
Thank you. And then, so that would make that appear full screen?
Yes. And one.
Emphasizes the importance of surgery as one of the key interventions to achieve universal health coverage. Universal health coverage?
これ音入ってんですかね。
And I'm referring here both to the geographic
全く
as
聞こえないですけど、向こうで切ってるからですかね。
aspects of universal health coverage. I say this.
Okay. Okay. なんとなくはいでちょっと切ってます。
directly from the computer.
Can we play one video or is it just not possible?
Mm-mm.
So we're gonna play this. Are you okay to play the other videos?
Yes.
And are you gonna be back here or are you gonna be up here?
Up here.
Okay. So you'll be up here for the Jim Kim and sorry,
Mhm.
it's okay. Okay, perfect. Awesome.
Do you see that?
Do you want to introduce yourself?
I could introduce myself. Ladies and gentlemen, may I ask that you take your seats, please? We'll be beginning in 1 minute. Thank you. Good afternoon, ladies and gentlemen, distinguished guests. Good afternoon. Good. Buenos dias, bon dia, bonjour. I learned one, konnichiwa. Thank you for joining us today for a lunchtime dialogue on the power of surgical care to catalyze universal health coverage. I would like to welcome all of you on behalf of our event hosts, the World Health Organization, and the governments of Zambia and Zimbabwe, in coordination with the Global Alliance for Surgical Obstetric Trauma and Anesthesia Care, or the G4 Alliance for short, and the Harvard Program in Global Surgery and Social Health. This event was also made possible in partnership with and the great support of Johnson & Johnson. Thank you, Johnson & Johnson. My name is Ambassador Dr. Neil Parson, and I serve as the chairman of the board of directors of the G4 Alliance, a network of over 85 member organizations working in more than 160 countries around the world to support, increase access to life-saving surgical, obstetric, trauma, and anesthesia care as part of universal health coverage. Our event today, ladies and gentlemen, falls on UHC Day, a global movement that calls upon countries to ensure that everyone, everywhere, has access to high-quality, affordable health care when needed. The concept of health for all is enshrined in the WHO's constitution, which declares that the highest attainable standard of health should be a fundamental right of every human being. And I dare say, without surgery, which is what we are here to discuss today, without surgery, health for all becomes partial health for some. We are here today because we firmly believe that surgical care is an integral part in achieving universal health coverage. And it is also an important strategy to manage and treat some of the world's most urgent health challenges, such as obstructed labor, fistula, trauma and injuries, as well as NCDs, including cancer and heart disease. We are pleased to be welcoming a diverse panel of speakers here today who will share their experience working to develop national strategies that integrate surgical care as part of the UHC plan. We will also be highlighting innovative financing strategies to integrate safe, affordable surgical care as part of robust health systems to ensure health for all. This movement, ladies and gentlemen, involves all of us. It is a truly multilateral, multidimensional, multivectoral approach in ensuring access to rights and equity and having optimal social impact. Before we proceed to the panel, I am pleased to introduce some of our event hosts to share welcome remarks. Dr. Jim Kim, the president of the World Bank Group, wasn't able to join us here this afternoon due to a travel conflict. However, he has graciously shared a video to welcome all of you to this event. We will now proceed with the video.
Hello, everyone. I want to thank you for attending this important event on the role of surgical care as part of the Universal Health Coverage 2017 Forum. Achieving universal health coverage is one of our key missions at the World Bank Group. We're committed to ending extreme poverty by 2030 and boosting shared prosperity for the poorest 40% by accelerating inclusive, sustainable economic growth, by building resilience to shocks and threats, and by investing more and more effectively in people. We can't get there without universal health coverage. Surgical conditions represent nearly a third of the global burden of disease, so surgical care is critical to achieving UHC. Surgical care is also a crucial component of building strong health systems, but one that's often overlooked. It's essential to treat and manage a broad range of conditions and disease categories, including maternal and child health, trauma, non-communicable conditions, and infectious diseases. Surgical care at the district level has been shown to contribute to a 10-fold increase in economic activity, as well as improving the health and well-being of families and entire communities. And most importantly, every 2 seconds, a person dies because of a condition that could be treated or managed with surgical care. But right now, 5 billion people cannot access safe surgical and anesthesia care when it's desperately needed. The poorest third receive only 6% of all surgical procedures. And as many as 81 million people are impoverished each year while seeking the surgical care they need. There are many barriers, such as health workforce training and availability, the distance to care, lack of essential medicines, and out-of-pocket costs. We must commit to overcoming every one of these barriers. The cost of increasing surgical capacity by 2030 is not negligible, an estimated $350 billion. But compare that to the $12.3 trillion in lost GDP in low and middle income countries if we don't invest in essential surgery and anesthesia. The World Bank Group will continue to help in bringing private sector solutions and funding mechanisms that integrate surgery, anesthesia, and obstetric care as part of health system strengthening initiatives and the effort to achieve universal health coverage. Our global financing facility is a good example of an innovative funding mechanism that's integrating timely access to quality surgical care through the provision of emergency obstetric care and cesarean sections. We need all of your ideas to help close this gap and ensure that essential surgical care is available for those who need it most, at every income level, in every country, everywhere in the world. Thank you for being part of this important discussion. I look forward to hearing the results.
Thank you. In his absence, I wish to thank Dr. Kim. Dr. Kim has prioritized poverty alleviation and the importance of UHC as part of this global objective. We are delighted that he has expressed his support for the role of surgical care in achieving our UHC goals. We are also pleased to have received a letter of support from the foremost UHC global champion, Director General of the World Health Organization, Dr. Tedros, who unfortunately is unable to be here, and we would surely make the letter available for your circulation, consideration, and for your noting. I now have the pleasure of introducing Mr. Maxwell Dapa, who will also be sharing welcome remarks on behalf of the UHC 2030 Secretariat. Dr. Pa, may I please welcome you to the podium, please?
Good afternoon. It's a pleasure to be here amongst surgeons, so it's a bit intimidating, but I think I'll do my best. First of all, thank you for inviting the UHC 2030 to this very important event. As emphasized by Dr. Kim, this event couldn't have been organized at a better time. And the UHC 2030, where I work as one of the co-leads of the Secretariat that is co-chaired by the World Bank and the WHO, do recognize the importance of this gathering. And that is to say that, as we all know, the march towards UHC by 2030 is ongoing, but we also recognize that there is a very limited time left. Yesterday, there was an important meeting of the steering committee of the UHC 2030, where the point was made clear that we are only down to 12 years, in essence. So it's no longer as far as we thought it was, and so there is the need to even accelerate our efforts collectively to achieve UHC by 2030. And we recognize that the work of this association is critical to this process. Dr. Kim just mentioned that about 5 billion people do not have access to high quality and affordable surgical care. The majority of these people are the vulnerable and poor people in communities and in countries. And so we believe that this association's work would help to elevate this particular class of people and also help to improve access to surgical care, which is an integral part of UHC, the UHC agenda. But just to give a brief sort of overview of what the UHC 2030 is about, as most of you know, in the MDG days, there was this partnership that was formed, which was called the IHP+, which stands for International Health Partnership Initiative. And the overall goal of the IHP+ was to improve upon development effectiveness in countries. That is to say that the support that development partners provide to countries in the area of health should be aligned with country systems, and that countries should take ownership over the implementation of these aid that is provided. And so, you know, we all know the MDGs have expired and we've moved on to the SDG era. Now the goal is on UHC. And so there was a thought to move away from the emphasis on donor aid to the use of countries' own resources in financing the UHC agenda. And that's how the UHC 2030 was formed. And so this is a platform to accelerate the movement towards the achievement of the universal health coverage target under the SDG 3.8 by 2030. So it is an inclusive and a multi-stakeholder platform that allows for building synergies across networks and partnerships and collaboratives that are working in the space of UHC. And we very much see the G4 as an integral part of this. So we'd like to encourage and also commend the leadership of G4 for organizing this, especially at the UHC forum here in Tokyo. And I think this sends a very strong signal about the intention of this group to be a part of the global community in fostering greater efforts towards the achievement of UHC by 2030. Thank you.
Thank you, Mr. Dapa. We also thank the UHC 2030 Secretariat for hosting us for this important forum, and we surely look forward to the opportunities for collaboration with UHC 2030 to ensure that surgical care is prioritized and part of national health plans. Next, we will be having a very brief video from Dr. Sanya Nishta, Chair of the World Health Organization's High-Level Global Commission on Non-Communicable Diseases.
Excellencies, ladies and gentlemen, good afternoon. I was delighted when I got to know about your event, which boldly emphasizes the importance of surgery as one of the key interventions to achieve universal health coverage. Universal health coverage is simply incomplete without access to surgery. And I'm referring here both to the geographic as well as the financial access aspects of universal health coverage. I say this with conviction, with concern, and with a lot of passion. Like most of you, I wear several hats. If I put on my NCD Commission co-chair hat on, I know well, as you do too, that surgery as an intervention has a significant role in the response to non-communicable diseases and injuries. One of my several other hats involves overseeing an access to surgery program called Heart File Financing in my country. On a daily basis, I hear stories from my teams and volunteers of osteoporotic elderly women with broken hips who would be taken away from the hospital bedridden and crippled for life if someone didn't pay for the needed nail to fix the joint. Over and over again, I hear heart-wrenching stories of families who become heavily indebted while paying for life-saving surgical procedures. Imagine a laborer with a broken leg waiting for a family member to sell a cow back in the village to pay for the operation, or parents who have decided to forego heart surgery of their child because they know how high the opportunity cost is and what a life of further impoverishment this will lead to. And it is not just the financial access aspect that is the problem. Across the continent of Africa and in many other countries of the world, individuals do not have geographic access to essential surgery. Those that can afford will travel overseas, but the poor will simply forgo treatment, die prematurely, or live with the disfiguring consequences of disease. There can be nothing more dehumanizing than failure of systems to come to the assistance of people in such great distress. And it is critical that we pay attention to the huge unmet surgical need in the developing world. According to official statistics, as you know well, 5 billion people do not have access to safe, timely, and affordable surgical care. 9 out of 10 people in the low and middle income countries do not have access to surgical care when needed. And this may just be the tip of the iceberg. This is simply unacceptable. Let us recall that in 2015, the World Health Assembly Resolution 6815 was passed unanimously by the member states. The resolution called for strengthening of emergency and essential surgical care and anesthesia as an important component of universal health coverage. We must make sure that we pave the way for translating these commitments into action at this seminal meeting. I thank you for your attention.
And I wish to thank, in her absence, Dr. Sanya Nishta for her work and her continued support of this global cause. Thank you. Makasa to join us to set the stage for our panel and our discussions here today. Health, the permanent mission of the Republic of Zambia to the United Nations office in Geneva, Switzerland. Dr. Makassar championed the essential role of surgical care and anesthesia as part he successfully advocated for member state support of the 2815 on universal health coverage. He further worked with the WHO member states to call for national surgical systems strengthening as part of robust UHC plans. My friend and colleague, Dr. Emmanuel Makassar. Welcome, sir.
Thank you, Ambassador. Good afternoon, ladies and gentlemen. I begin by thanking our co-sponsoring partners and the UHC 2030 Secretariat for enabling us to have this side event. I'll speak on behalf of the member states, probably representing the Republic of Zimbabwe and Zambia as the co-sponsors here. Like Dr. Nishta said, the member states mandated us as diplomats to negotiate and table this resolution 68.15 at the World Health Assembly in May in 2015. And you should remember that this was before the SDGs were adopted. So the member states were already forward-thinking, and in their wisdom, they decided that surgery and anesthesia should be part of universal health coverage. Probably many of you would probably question why was it that my government decided that we needed to approach this in that way. I'll backtrack a little bit. In a summary, we had started implementing our commitments to the MDGs. And by 2010, we had to make an assessment to see how far we were going to actually achieve our targets. And one area we looked at was the issue of reducing maternal mortality and child mortality, which involves under 5 and infant mortality. And that assessment clearly indicated no matter how much money we'd put in, that we were not going to get to our targets to get the MDGs. And so the question was, why was that not getting, why were we not going to get to that with all the investment that had gone in? And the quick assessment at the time made us realize that our emergency care, emergency obstetric anesthesia and surgical care, were not available at the district hospital. They were not available at the primary level of care closer to the people. And so we wanted to develop policy to see how we can try and bridge that gap. And we didn't have any policy at national level. And neither did the WHO have any policy at the global level or regional level to actually help us move that agenda. And therefore, so we had to table a resolution. And we tabled this resolution to try and push this more so as a component of universal health coverage for us, because surgery, unlike any other program, which were very disease-specific, as you know, from the MDGs and before, everything was financed in a disease-specific way, malaria program, TB program, and things like that. For us, surgery was not a disease-specific program. Surgery was a cross-cutting piece. Besides it meeting the needs of the unmet need, like Jim Kim and Sanya Nishta said, it was also very cross-cutting in that it was going to help us to achieve a lot of other things, because surgery, like I said, is not a disease. Surgery was going to help us strengthen the health systems at the primary level, where most of the health systems are not fully developed. Surgery was going to help us with emergency preparedness and response. And as you know, when we talk emergency preparedness response, we're talking all hazards. We're not only talking infectious diseases. Surgery, in fact, is the first thing. Whenever there's a war or an earthquake or whatever happens, surgical interventions are the primary and the first thing that comes through. Surgery for us was going to help us, like I said, meet our targets in maternal and child health. What kills mothers and babies around birth? The intervention is always surgical. It's not paracetamol. And surgery for us was going to help us reduce disability, physical disability, whether it's congenital or acquired. Acquired in the sense from road traffic accidents, industrial, home, domestic accidents. Surgical interventions are the ones that can get us that. And if we reduce disability, we increase the economic output and performance of each individual, which helps the family, the community, and indeed the country at large. For us, surgery was a way of trying to control antimicrobial resistance. When we link it now to the more newer discussion, in fact, the discovery of AMR was to do with surgical site infections. In the developing world, we have a lot of infections, bone infections, and a lot of other things where we use antibiotics inappropriately. So it would be a key driver that we can use to try and not only increase awareness, but also try and prevent antimicrobial resistance. Beyond the technical health things, for us surgery, because we had a huge gap of health workers within the service, For us, it would be a way of imparting the rightful skills in our youth so we create employment. And as you know, creation of employment is a key thing for government. Surgery for us would be a way of empowering women. Most of the surgical jobs in the surgical team are managed by women, anesthetists, nurses, and all that, and obstetricians, and indeed in, other cadres that help us in that field. So it would be a good way of getting good jobs, long-term jobs that are well-paying for women. So it's empowerment of women, and of course, like I said, for national development. So for us, these were the cross-cutting issues where surgery for us was a key piece that if we developed, we don't only achieve universal health coverage, but it also would be a way of addressing other national development issues. So we then tabled the resolution, and this resolution was, like said by Sanya Nishta, adopted anonymously. But the resolution was followed up later this year. In May, the countries, the member states of the WHO itself, and the partner organizations recommitted themselves to ensure that this resolution is actually implemented through the decision 70.22. This resolution or decision point actually in May says that member states of the WHO together with the partners have to report on how they are implementing their commitments in the resolution passed in 2015 until 2030. So we've already got the political commitments, and we've developed, we're in the process of developing global policy through the action plan, and the roadmap has already been developed, through which we can translate the global policy into national policy and then to investment and action. At this stage, we are at the level of developing national action plans or national plans, national surgical obstetric and anesthesia plans. The Republic of Zambia has already finished that process, and this document is already costed. Ethiopia already did a lot of this work, and you hear from our colleague from Ethiopia and how far we've gone. Many countries in our sub-region, in Sub-Sahara, are in the process of developing their national action plan. They still need support. They're still going forward, because this shows how serious they are. And I think many other regions also are working on this field. So that's the stage where we are at, and they need support, and we're now translating the global policy into national policy for implementation. It's important to state at this stage that there's many platforms where countries could work together with other non-state actors to ensure that they can accelerate their development of policy, and also in the implementation phase, they need to partner with a lot of other organizations. It's also important to say that these national action plans have to be customized or integrated in the national strategic health plans. In Zambia, the national plan is integrated in the national health plan, which is also part of the 7th National Development Plan. That is very important, because as we go forward, financing for such programs have to come mostly from within the country. We cannot always look for resources from outside. And for it to be sustainable and integrated nationally, that's the only way it can have budget lines coming from government. So that's very important. And so for us, we don't really think as a country that we can achieve universal health coverage without surgical services, especially at the primary level of care. And for us, surgical services are a masterpiece. We think, like I've explained earlier, if we can implement this, we can achieve a lot of targets, we can meet a lot of commitments and a lot of goals, we can meet more than, we can hit a lot of birds with just one stone. So we are hoping from this panel discussion, we can, work out mechanisms of how we can work together, because we already have the political commitment. The investment case has already been made by the Lancet, the World Bank through their DCP3 publication. The burden of disease and how we can move forward has also been articulated by the Lancet Commission on Global Surgery. What's only remaining is us translating the global policy into national policy and then moving on to action. So we hope that we can put our heads together and ensure that we can meet that commitment and save the world by providing safe surgery.
Thank you very much, Dr. Makasa. We are always inspired by your commitment and your ardent support for this issue. Thank you for championing the role of surgical care for the billions of people who need it the most. Next up, ladies and gentlemen, I'd like to invite our panelists on stage to join us for what we know, not hope, what we know will be a dynamic and engaging dialogue that will include questions and discussions with our audience. Bearing in mind we have many persons following us online as well, and thank you for joining us online. I would wish to welcome to the front our panelists, seating to my immediate right, starting with Dr. Abraham Menjitsu, the Save Surgery 2020 Project Director of JAPIGO. Dr. Jane Connery, past president of the American Congress of Obstetricians and Gynecologists and chair of the Women's Preventive Services Initiative. Dr. Per Theodore, Vice President, Medical Devices of Johnson & Johnson. Mr. Francis Hatta, Chief Growth Officer of G Healthcare Japan. Mr. Blake Alkire of Harvard Medical School. Dr. Agnes Sukat, Director, Health Systems, Governance and Financing of the World Health Organization. And I would also like to welcome to the front our two co-moderators, Dr. Emmanuel Makassa and Meera Mahesh of the G4 Alliance. I would happily pass the floor to our able-bodied moderators.
Welcome, everyone. Thank you for joining us for lunch. We have a dynamic panel, and we're excited to jump in. So without further ado, we'll turn to our panel. So what we've brought together today is a really dynamic group that represents what countries have been doing on the ground and what experts in the field recommend in terms of our progress to integrate surgery as part of UHC. We have representatives from the private sector who can speak to us about their reasoning for wanting to prioritize surgery. And then we have some two wonderful experts here who are going to speak to us about both the financing and integration of surgery as part of health systems. Why don't we start with Dr. Abraham Mengistu. So Dr. Abraham, you've worked with the Ethiopian Federal Ministry of Health in your former life as part of the group that helped to develop the first ever national surgical plan, and this was the Saving Lives Through Safe Surgery initiative. And subsequent to that, you shifted to a nonprofit to work on the implementation side of things. Could you tell me a little bit more about why Ethiopia decided to prioritize surgery as part of their UHC plan and what the experience of developing the national plan was like?
Thank you so much, Meera. Good afternoon, everyone. And I'm really pleased to be here to share the experience of developing, the Ethiopian National Surgical Plan. I think it started way back in 2015, and there were a number of factors actually driving the process. We had some global factors like, the resolution from the World Health Assembly prioritizing safe surgery, including some of, the seminar reports from the Lancet Commission and the World Bank. But we had also local factors like, at that time we were developing the national 5-year strategic plan, which we were prioritizing, essential clinical care like surgery. As much as we had also these national priorities, we had also, local driving factors. Some of the regions who were implementing primary care in Ethiopia, they had this community-based insurance system, which they listed surgery as a package, but they were not providing, surgery to the public. So there was also this local factor. And the government was also trying to kind of improve maternal health by building a number of primary hospitals. These hospitals have been built for a population of 100,000 population in each of the districts, but at that time they were not functional. They were meant to provide safe surgery. So these were some of the driving factors, the circumstances that led, to the development of the national plan. So immediately after attending the World Health Assembly, the minister at that time, Minister Kaseta Brahan, came to myself. I was the director of medical services. He said, look, I think this is something that we need to prioritize. It's in line with our health sector strategic plan. And we got to use also the opportunity of the resolution. So that was how actually, even we named it that day, we have to call it Saving Lives Through Safe Surgery, abbreviated as SALTS. Now if you call SALTS in Ethiopia, it's very common to name it. So the next thing that we did was looking for, important stakeholders like professionals. We don't have a unit at the Ministry of Health to do surgery. We don't have any surgeon, anesthesiologist, or obstetrician working in the ministry. So we got to look for available resources, be it in the professional societies, be it in partners like, JPAGO and the others, working at that time. So we formed, a kind of a unit at the ministry that will help us coordinate all these activities. but looking for also this partnership between professional society, senior professionals engaging in safe surgery. So we had a number of interactions, and what came out after that was, this is very important. We got to ensure access to equitable, safe surgical and emergency obstetric care. But have we defined the package specifically for Ethiopia? That was the issue. That's where, we went into defining an essential surgical, obstetric, and emergency safe surgery package for Ethiopia. This has been a process, very iterative, different working groups working on different programs, which ended eventually into 56 procedures, including obstetrics, including injuries, all the other essential procedures, a special package in Ethiopia that the government is committed to provide to the public, as a right, to the population. And these packages have been defined, what can be done at the primary care level, what can be done at secondary level and tertiary level. It turned out, more than 90% of these procedures actually could be provided at the primary care level, ensuring, the universal health coverage. So this was really a long process, and we had a number of interactions, not only with professionals, but, people at the regional health bureaus, at all levels of the society. So eventually, once the package was designed, it was easy to quantify some of the resource implication to implement the package, the kind of human resources that we need to implement this package, all the others. So the souls became, kind of very visible as we go along. So it had, all these 8 pillars, saying that if we could do right, implementing these 8 pillars, which include obviously the governance and the leadership, supplies and equipment, the advocacy partnership, and all the other pillars, that would result into making, essential and emergency safe surgery accessible to the whole population. So I guess the process was really a long process. It took us almost a month. We started in May, but, we had the whole picture in April. And as I told you, the process was very iterative, and we made it a point that, most of these procedures could be done at the primary care level, where the people are. And we made it also a point that, it covers the most essential procedures, including cesarean sections, including, trauma management, including, the acute emergencies, which are really killers, for the people on the ground.
Thanks, Dr. Abraham. And clearly, it sounds like it was an iterative process, and it was a process that brought multiple stakeholders to the table. What I might do is we can come back. I'd like to hear more about your transition, but I think I'll loop it in with one of our other panelists, because Dr. Abraham subsequently left the federal ministry and went to move on to work with a partnership called Safe Surgery 2020, which brings together private sector with NGOs, including JPIGO, who he works with now. But what I might do, I'll come back to that in just a moment, so I haven't forgotten about you. We're also pleased to have Dr. Jean Conry. And if you don't mind for the panel, do you mind if I call you by the first name, just so we can have a dialogue?
That's fine.
Thank you. All right, so Abraham, Jean. Jean comes to us from a long background working in obstetric care, and represents the American College or Congress of Obstetrics and Gynecology. So as an expert in this field, we often look to maternal and child health as a model for how do professionals and folks in the development world bring access to care for an issue that is really important and impacting millions of lives. And it seems there are a lot of cross-section or cross linkages between surgery and obstetric care. And we also look to often the SDGs as a guide for the framework that has really informed how investors and private sector and nonprofits have invested in this issue. Can you tell us a little bit more about the linkages between surgery and obstetric care, and maybe if there are some lessons from obstetric care that you can share with the surgical community, which really should be one. Surgery and obstetrics go hand in hand.
Thank you. This is really one of the key concepts for all of us, because when we start looking at decreasing maternal morbidity and mortality, when we look at how we improve the health of an infant, it really relies on the integration of surgical care and primary care. Let me give you an example. When we're looking at a woman who's pregnant, we've tried to optimize the health of her before she becomes pregnant. What's her well woman care? We've tried to optimize her access to and ability to use contraception so that every pregnancy is a planned pregnancy. Our focus is also on the environment. How do we reduce environmental exposures, whether we're talking something like lead exposure, organophosphates, endocrine disruptors, to optimize her health. And then providing prenatal care and the optimum birth experience with birth attendants, whether we're talking about midwives, birth attendants in the field, or the necessary cesarean section or operative delivery. How do we integrate all of those is the key to providing the best for maternal mortality, to decrease maternal mortality and morbidity. And what I'd like to say is it's not an either-or situation. It's really highly integrated. There are about 120 million deliveries a year, 250 deliveries every minute. And at the time we're talking this morning, there will be 400 cesarean sections. So it's incumbent upon us to make sure that the health of a woman and the health of that child is taken into consideration, and that every cesarean section is an indicated cesarean section. In obstetrics and gynecology, we view access to obstetric care as a means of reducing maternal mortality and morbidity, as a means of reducing obstetric trauma, and a means of reducing fistulas, complications like sepsis, and then making certain that the continuity of a community is maintained, because we're looking at the health of the woman and making sure that the health of that woman is maintained and the health of the child. So we're looking at this from a community view or glasses. We recognize that preventive care and safe surgery or alternative treatments improve women's health around the globe. Easy access, for example, to progesterone IUD can reduce complications from pregnancy, so that a woman never conceives, or it might reduce menstrual periods so she avoids a hysterectomy. They are not either-or situations. It's fully integrated. We make sure that she's got access to what she needs so that planned health is priority. And it's the access to surgery, the access to primary care prevention, and the ability to put a woman's health first. It's clear that primary prevention care and surgical care are not opposite ends of the spectrum. And then finally, when we address routine gynecologic care with cervical cancer screening, for example, we're preventing cervical cancer screening, whether we're talking about HPV or cytology, but early surgical intervention is absolutely critical. We can avoid a hysterectomy by the appropriate surgery early on. We can save a woman's life by providing the appropriate timing for a hysterectomy. And we can avoid the morbidity and mortality of cancer if we've got early surgical intervention. And sometimes we ask, what do we gain from all of this? And to me, what we gain is the health of that woman in the community. Because in the end, we're looking at the glue for the community fabric. We're looking at the family's health. And the only way to preserve the family's health is by maintaining the health and the viability of the women in the community.
Thanks so much, Jean. Clearly, I think we have a lot to learn from the integrated model that the obstetric and gynecologic community or maternal and child health community use, but I think it will be interesting to work with your community to make sure that as we're integrating surgical plans, obstetric care is there, and you have a long legacy of developing standards, guidelines, training models that we can certainly learn from.
Thank you.
Thank you. Next, we'll go to Dr. Pierre Theodore. So Pierre is coming to us both as a practicing thoracic surgeon, but also somebody who's working in private sector with medical devices at J&J. Pierre, Johnson & Johnson has a long legacy and history of combining innovation with ingenuity and compassion to help address some of the world's biggest issues. And we're really pleased to be bringing private sector as well as a practicing provider to the panel today. As part of your commitments to global health, J&J has identified 5 pillars, 5 key areas of focus that are targeted to provide access to care and to align with the Sustainable Development Goals. And as part of this, J&J has committed to really help 50 million people within 5 years as part of this strategy. And one of your key pillars happens to be essential surgery. We were really impressed when we saw this, so this is great. But can you tell us more, what inspired J&J to prioritize surgery, and how do you see this as being integral to supporting Health for All in the UHC platform?
Thanks, Mara. And first of all, I just want to say thank you to you and to Ambassador Parsons for the invitation. I think it's fantastic you put on a conference specifically dedicated to surgery. If I could, I just would say from J&J's perspective, if you look at the history of our company, it was founded in around 1880, 1886, around really identifying problems first and foremost, unmet needs, and then trying to consider what is the underlying basic science that is responsible for managing that issue, and then translating a basic science observation into a solution for that unmet clinical need. So that's really been our modus operandum for 130 years or so. And that still is the case with essential surgical surgery and access to surgical care. We find an unmet clinical need, and we think about the products and the processes that are key in order to impact that. You mentioned the possibility of addressing 50 million people in 5 years. We can do that through a combination of approaches, including teaching clinicians. So we have a very active program in education, first and foremost. And furthermore is what you might call market-appropriate innovation. So we put out calls and challenges. We try to find innovators specifically that can bring low-cost solutions to the needs of patients in low-resource environments. And finally, I would say from a sort of a health economic standpoint, there's something, as you all in this room know, called the sort of the iron triangle, which is really where you're trying to balance access to care, the cost, and the quality. And some of my colleagues in J&J were saying sometimes there are discussions, should the private sector be part of these discussions about global health? But from our perspective, if you really are talking about delivering high-quality care, that has to be in partnership with industry, because we bring the products that the surgeons and the clinicians are using on a day-to-day basis to deliver care. So we are part and parcel of that process of improving quality and trying to drive down costs.
Wonderful, thank you. I love that, the access, care, quality, iron triangle. I think that's a great metaphor for us. I think now's a good time. I might hand it over to Mr. Francis Hata. And Francis comes to us from GE Healthcare in Japan, and we're delighted to be welcoming someone based in Japan. Mr. Hata, or Francis rather, if you don't mind, GE Foundation has invested $25 million in safe surgery through an initiative, a 3-year initiative that will enter into 3 countries, and hopefully will reach also a similar target, 50 million patients. Dr. Abraham Mengistu, so Abraham mentioned some of his involvement in Ethiopia with the national plan, and subsequently he's gone on to work with Safe Surgery 2020. I wonder if you can tell me more about this initiative and maybe some of the, I guess, outcomes or key findings or interesting things that you want to share that have resulted from your first 2 years as the initiative.
Yeah, and thank you again for the opportunity to present on GE and GE Foundation's activities. And maybe let me just start again in terms of what motivated GE in terms of getting into this area. And I think it was discussed before in terms of the data, let's say, and with 5 billion people in the world not getting access, and also I think it's 1.5 million people every year that are not benefiting from safe surgery. And so with that underserved population, we wanted to combine GE's core competencies or capabilities, and we thought this, how do we serve this underserved area? And so, in regards to that, there are many things that GE has done in the past. Just as a company, we're very much a solutions and innovation company, and so we wanted to bring things similar to what Dr. Theodore just mentioned that J&J is doing, but it also involves things like training and professional development, leadership development, and also in terms of planning, in terms of surgical planning for the area. And so I think the important piece is how to develop the ecosystem there, where one thing is to provide the funds and the necessary capital that's required, but the other piece is really how do you develop ecosystem that's sustainable moving forward. And so that's been kind of a key driver for our activities over the last couple of years. And then, for example, 5 different areas that we focused on. And again, as I mentioned, workforce development is one very critical, important piece. Leadership transformation, working closely in the understand in terms of the cost and so what it means to develop a system there. And working with the government to kind of press that forward has been actually very powerful. So I think that's been a very great outcome and a good example of some of our initiatives in safe surgery.
Wonderful, thank you. And Francis, you mentioned that you look at it as an ecosystem, and I think that's an approach all of us here take. We look at it as a whole system approach, and I don't think we'll achieve UHC if we're not looking at all the factors that come into play. And as one important factor you mentioned is financing and the economics of everything. So our next speaker, Dr. Blake Alkire, so Blake has actually done a lot of work in economic modeling, and he was part of the World Bank Disease Control Priorities Essential Surgery Report that came out a few years ago, and the Lancet Commission on Global Surgery. And some of the work he did has produced data that didn't exist before. We really didn't know what the cost or the burden of not providing surgical care as part of a primary package of healthcare was. So Blake, can you tell me a little bit more about some of the key findings from these studies and how it impacts the way we should look at UHC and surgery?
Absolutely, thank you. And I'd just like to start by saying it's an extreme honor to be here at the forum and to be on this panel with so many incredible, accomplished people. My research really began in 2010, and at that time there had really been development of could be cost effective and in fact could be very cost effective. And so at that time, the program in global surgery really started to thinking about using benefit cost analysis. And so it's worth mentioning that about the time that we were looking into employing these techniques to really identify return on investments, Professor Dean Jamieson, who many of you know was a co-chair on the Lancet Commission Investing in Health, co-authored a paper for the Copenhagen Consensus in 2012 that did a benefit cost analysis that looked at scaling up essential surgical services for maternal health and for injuries, and found that at a minimum, for every dollar invested, $10 was returned. And so our work sort of looked at more disease-specific interventions and led to one of the chapters in DCP3 that you mentioned. And so we looked at two diseases. We looked at cesarean deliveries in countries that had already been identified as under-delivering, and we looked at the return on investment for cesarean deliveries for obstructed labor. And, thinking back, I will admit to you that we used the most conservative approach we could because we didn't want to overstate our case, and I sort of almost regret that. We found that of the 47 countries we examined, the median return on investment was $4 for every $1 invested. But when we use actually a more common methodology and approach that is found in the literature, that number actually jumps to $30. Return for every dollar invested. We found similar numbers for investing in cleft lip and cleft palate in India. And so we then turned our attention to the Lancet Commission, and I won't belabor the details since we've sort of heard these numbers, but I was fortunate enough to be involved in trying to figure out how many people don't have access to surgery. And I just think it's worth mentioning that one of the key things that the Lancet Commission did up front was take a multi-dimensional approach to access. And they said, it's not just that you have to have surgery and that it's safe and that it's timely, but you can't become poor because you pay for surgery. And so when you look at all four of those aspects, we found that, as you know, 5 billion people don't have access to surgery. And then finally, I was lucky enough to be involved in the macroeconomic part of the Lancet Commission. And WHO was kind enough to lend us a model that they had developed to forecast GDP losses for disease-specific programs. And when we adopted that for surgery, we found that over a 15-year period, the low and middle income countries that we were able to examine in depth would lose at least $12.3 trillion over a 15-year period. But I think the better case is stated by the proportion of potential GDP loss, which in low and middle income countries approach 2% by 2030. So, there's a strong case to be made for surgery as a necessary and crucial component of UHC, but also a strong economic case as well.
I'm convinced. Are you convinced? To introduce our next speaker, Agnes Sukat. May I call you Agnes? It's a pleasure to have you today. Dr. Agnes comes to us from the WHO. She's Director of Health Systems, Governance and Financing. And Dr. Sukat, or Agnes, I'd love to hear more from you about, we've heard different aspects of this issue. We've heard it's an ecosystem issue that requires various actors to participate. But how do you recommend that we can better integrate surgical care as part of, really as a cross-cutting component of health system strengthening and the work that you do?
Thank you very much. And I would like to start from the SDG price tag we published in July 2017 in the Lancet, and in that analysis, what we identified is that most countries have, in a way, 4 service delivery platforms that they can invest in. One being a community-based, cross-sectoral platform that doesn't really require skilled health workers. Another one, which is a more advanced outreach periodic type of service delivery platform. This is how we deliver immunization, and we deliver periodic care, such as distribution of vitamin A and other treatment. And then we have clinical care. We have the first level clinical care, the primary health care, together with the community care. And then we have that specialized care platform, right? And that specialized care platform often has, in a way, a secondary level of priority. You hear a lot like, it's all about primary health care. But the fact is, no country just stops investing into primary care. It just doesn't happen. And second is that, in fact, a lot of the impact of the first level care, particularly in maternal health, is actually achieved only when you have referral care. So the impact of a high quality assisted, you can refer the difficult cases to a functional referral care. So this idea that we can oppose the different service delivery platform on a pathway to UHC goes only that far. It's very quickly you reach the limit. So the question is much more about how you carve a pathway in which you make the right investment in every service delivery platform, right? So it's really, what is it if you need hospitals that respond to the most pressing issues in the countries and address both the emergencies and respond to surgical issues that have cost-effective responses. Then in what kind of hospital do you need to invest? In what kind of health workforce you need to invest? That's the question. And how you build progressively your system, because this is not something that is happening in a year. Right? It's not like distributing bednet. If you actually want surgical capacity, it's going to take a few years, if only, to get the human resources. And this is where our work is actually proved useful, because what it shows is all countries can start tomorrow, maybe today, right? All countries can actually start investing. And the first investment is actually human resources. Because here, when we're talking about technologies and we're talking about different things, but the heart of surgery is the skills, is the human resources. And today we live in a global market in which we actually have an incredible shortage of skills, not only of surgical skills. In fact, the shortage is very, very high in surgical skills, but even in basic medical skills or even in basic scientific skills. And as you know, training a surgeon takes a few years. So if we really want people who are capable of performing surgery, we need to invest now. scientific training of students, both in high school and in universities, and we need to start investing in that workforce. Today, as I said, this is a situation of shortage. What does it mean? It means we have a situation in which money is chasing health workers. So that's not really an issue of money, and that's what our SDG price tag showed, is every country can actually start tomorrow and start investing. And that's from domestic funding. Right? It's investing in pre-service training. It's also investing in those sort of basic services. And we know, I started my professional life actually as a resident in obstetrics. So that's the world is a small place, right? In Benin Republic. And at that time, and still to the day of today, the country is reaping the benefits of what a visionary obstetrician at that time, Professor Alionu, had done, which was really to invest in the training of obstetricians. And the entire country had actually trained obstetrician in every district hospital. It was very different from the other countries because he made that choice. So the issue of leadership in actually investing in pre-service training is extremely important. And the other point I'm going to make is, so that was the point about domestic funding. But when we think about investment that could come from external funding, one is external funding can be channeled towards pre-service training. This is an investment. So this actually it can be a one-time investment. It doesn't necessarily carry recurrent costs. And you hope that by the time the recurrent cost will pick up, the country will be richer. It will have more fiscal space. It will, within 5 years, 6 years, 7 years, the countries will be able to pick up the wages. But you need to invest now. And that's something that development banks, the World Bank, other banks can do today. They can invest in pre-service training. The other thing, which often is not known, is that you have many hospitals that actually don't have water and electricity. So let alone having a sophisticated theater, but that's something also that external funding, and in particular development banks, can do, which can do, again, tomorrow. There is IDA 18 as a record amount of funding of 75 billion. It is possible today to invest in actually having those hospitals really have access to water and electricity, and also community.
Brilliant. Thank you. So clearly, I think we understand that we need to start investing today, not tomorrow, and that it's really investing in surgical care or in health workforce or at any level really contributes to the entire health system, not just to a vertical. So with that, every country can start tomorrow, and you mentioned that health workforce training is a great place to start. I'll turn it back to Abraham. So with his work in Ethiopia, in your transition to safe surgery on the implementation side of things, partners, and worked on a number of initiatives, one of which was leadership training to strengthen surgical teams and to hopefully improve some health outcomes. Can you tell us a little bit about this experience and what you observed as the major outcomes of investing in providers?
Yeah, thank you so much again. And I think back in the ministry, when we initiated the SOLS program, we also realized, the importance of, key stakeholders like, private institutions, professional societies. So we, in fact, created a forum to coordinate, this stakeholders. So we had this initial relationship with so many development partners, GPIGO being one. So as we were developing the plan, we didn't actually wait to finalize the plan. We were implementing, some of the elements within the plan while the planning process is GE, the Medtronic, J&J, and all the others, available to support, the safe surgery initiative. So it was really a blessing back then when I was coordinating this initiative within the ministry to learn that GPIGO is kind of leading this leadership intervention through the funding from the GE Foundation. For I know GPIGO has been working for decades, to improve the lives of mother and families. And when I heard that also they are prioritizing safe surgery, so I saw that even now they've included it in their strategic plan. This is really a great take. We've developed the plan at the ministry, and we were about, looking on how we could implement it, operationalize it at the ground. So this was really a perfect fit for surgery in the context of Ethiopia. So it turned out, because of a number of interventions by the government in the health system, we have some infrastructure going on, health work development going on, some of the health system inputs are going on, and yet surgery is not happening. And as you go down into the primary care level in Ethiopia, you'll find not surgeons, you'll find not anesthesiologists, you'll find not obstetricians, but you'll find a different cadre of health professionals contextually trained to do some essential and emergency surgery. You'll find what we call emergency and essential surgical officers. These are non-physicians, providing surgical care. You'll find probably nurse anesthetist training, for a short period of time. So as we approach them, what they've been telling us, look, we've been assigned to do this, but, we don't have the leadership, we don't have the communication skills, we don't have the confidence, to do some of the surgical workforce. So their cause was, if they could be supported, slightly through this leadership program, if we could link them also with some senior practicing, surgical operators, number one, the system that they'll be working would improve. They will have also the confidence to do more surgeries, and this is exactly what happened. So this program developed into what we call a leadership program, basically identifying, surgical teams at the rural level, which include, non-physician surgeons, nurse anesthetists at best, including, the small staff that they have, and running them through a leadership course, basically providing them with skills in problem solving, problem identification, communication, and team building. So they'll be looking inwards to kind of sort most of their problems. And I think while doing so, we'll be linking them also to senior physicians, senior surgeons, obstetricians, senior anesthesiologists in town through a very structured mentorship program that the mentors would go down into these facilities, support them all the time. This process, while providing this capacity also would include what we call activating, the ecosystem. We'll be engaging, for example, with the hospital management, because we found out, for example, surgical teams were not communicating with senior management, who are really deciding on resources. We'll also support them on linking them to their regional health bureaus. These are, political administrations that make a lot of decision on resource allocation, human resource deployment. So this activation process of the ecosystem was a very important element of, our program. Of course, we support also the Ministry of Health, because that's where, the engine is happening in relation to what's happening at the ground level. So following this intervention, few months along the line, surgical teams started to talk between each other. For the first time, they were looking into solving some of their problems on their own. It turned out, the For example, some of the anesthesia machines are locked in the store, when in fact that's really an issue in providing surgical care. When in fact, some of the resources are available in the health centers, nobody knew what's right there. So this communication has really improved a lot of things in the surgical care. And the fact that also senior surgeons, senior obstetricians going into these primary facilities for the first time, that really provided a lot of confidence, to the surgical teams working there. So all of a sudden they started doing, a lot more cesarean sections. Previously they were referring them, even if they are complicated. So this has been really a very turning point. As they see some results, for example, by increasing the volume of surgery, then the regional health bureaus realized that, if they invest more on these areas, they would see, the volume of surgeries increased. This was really very interesting. But the communication bit also improved safety, because people started to improve, the system. That resulted into also using, the checklist, which was really very instrumental. And some of the hospitals also, identified that, they need to optimize the time to do decision to incision time, for example, for cesarean section, which was very, very long in some of the hospitals because of poor surgical system in their hospital. So overall, I think the performance of the team in relation to team building, communication has improved. This has resulted also, in the system, people started adhering to standards with increase in the volume of surgeries, and the safety issues, and as well as reduction of, the complications. So I think this has been the learning, but the challenge though would be, we initially did it in 2 regions in Ethiopia as a demonstration, so that, we develop, a viable model for the country to implement the SALTS initiative. But, these early results have been also sometimes a challenge, because the government was pushing for rapid scale up, and sometimes going for a rapid scale up without properly documenting the experience is one of the challenge, and that has put also a huge expectation on the initiative.
Thank you so much for that insightful experience. Just a comment. I'll basically comment on the key role of partnerships, public-private partnerships in the process, considering the Zambian situation. For us in Zambia, again, for us to have been able to to develop the plan and now moving into implementation, we should say that partnership was part of the key thing from the start. In fact, including the drafting of the resolution and tabling it, it involved partners. All partners were involved. The rapid development of the plan, we managed that in less than 6 months, which was unprecedented. Again, that would have never been possible without the partnership of other non-state actors. And as we move into implementation, yes, just like the Ethiopian situation, the Zambian government has made a lot of the capital investments in this. They have built the infrastructure. They are procuring most of the equipment. But there's other things like here, say the governance of the health system, information management of the health system to demonstrate impact, because we really have to demonstrate the impact of why people should put their money in there. If you put in $1, we have to show where the money is going and how it's really impacting the service delivery, the health system, as well as the patient. So for us, partnership is a key thing, and we look to partnership as we go towards implementation.
Thanks for adding that comment, Dr. Mukasa, Emmanuel. On the note of partnership, so it's helpful to hear how, I think in every speaker's discussion, partnership and collaboration has been a common theme. And I'd like to direct the next question to Pierre and to Francis. You both work for private sector, and I think people often go to private sector and say, okay, come on, help us out. But I think that's not really the model that embodies and encompasses the UHC, the spirit of UHC. So can you tell me a little bit more, in your opinion, what role do you think private sector can play in supporting UHC, and particularly surgery as part of UHC? And if you have any thoughts on innovative financing strategies that include partnership as part of that.
Yeah, thank you for the question. And I think the simple answer is I think private companies have a huge part in this, and so it's really very important that more companies get involved. And I also want to reference back to Dr. Alkir's Lancet study on the benefit to cost of 10 to 1. And companies often think about return on investment, but here's more the impact on investment. And so we already know the statistics from the safe surgery. I mean, it's a very much an underserved area, and so as a private sector lens, I do feel that this is an area that's, if we do invest, the impact is going to be big. And in terms of other companies getting involved, I've worked also at a different implantable device companies, and also now GE on the imaging side. We all have different expertise, right? And so I talked about that theme of the ecosystem, and I think that stands true here as well. We need different partners to provide different capabilities and expertise to really develop that health system or ecosystem. So again, just to reiterate, we have a huge part to play in this, and I hope that continues from other partners as well.
Yeah, I think Blake mentioned before about the return. And one of the key things is that when an investor invests in anything, he wants the risk minimized. And when the private sector sort of partners with Ministry of Health, partners at the governmental level, that's a form of sort of risk mitigation and risk reduction, which encourages investment. So I really can't stress enough, I think, the importance of really having industry being really sort of shoulder to shoulder with government level administrators in healthcare. And just to build on what Dr. Mikasa said earlier, is that having a national surgical obstetrics action plan in place is critical for industry, because it gives a blueprint as to exactly how resources will be distributed and what role industry can play.
Sorry, maybe just kind of add another comment to that. And again, also as global companies, we often have large footprints within these countries already, and so I think when large companies like GE or J&J make that initial investment, it actually creates a foundation or that driver motivation or avenue to really have other companies involved. And so I do hope other companies do leverage that in terms of the, we have local people on the ground that knows hospitals, physicians, and different aspects of the government as well. So I just want to add that comment as well. Thanks.
Those are important perspectives. Particularly, I love the idea of having a blueprint, a plan of action when you go into a country, but also making sure you can leverage existing networks, existing supply chains, et cetera. So that's really, really helpful insight. Just to build on this idea, there are existing partnership and innovative financing mechanisms out there. And one in particular, and this is something that we heard earlier Dr. Kim mention, was the Global Financing Facility within the World Bank. I'd like to ask Jean, you've got your background in obstetric care, and the GFF essentially looks at innovative partnerships and strategies to fund maternal and child health care. And I'd like to hear your thoughts on this fund, and is this something we might apply to surgery? And if you have any further thoughts on similar models that we could apply.
Thank you. Great question, because I think we all realize that it's the funding that makes a difference, and we see funding that effects change. We can then translate that change into improved health outcomes. I would suggest that the first thing that we need to be looking at is the capacity building. Dr. Sukat, you said it eloquently, that we need to be looking at how to train, how to create an environment that encourages simulation work, that encourages ongoing healthcare workers, and it's the training and capacity building that's actually the most important step. The second element to that, and this is where there is such potential, and I'll give you an example of what we've seen in obstetrics, and it translates perfectly into all the surgical specialties, has to do with the culture of safety and readiness preparation. In the United States, we have a Council on Patient Safety, and it is a collaborative effort between anesthesia, OB, family practice, our midwives and nurses on improving obstetric care, decreasing maternal mortality and morbidity. We've come up with a whole host of safety bundles, outcomes that we believe need to be followed to improve the care of a woman around hemorrhage, reducing the first cesarean section, thromboembolic disease, cardiovascular problems. We know that if we use systems, hospitals, health systems, that we can improve maternal outcomes. In California, we've seen a reduction in maternal mortality in a decade of 55%. So we know that we can effect change. We've now are collaborating with Malawi on the same, the acronym is AIM, but it's an alliance of innovation in maternal health. And we can effect change with the knowledge that's come evidence-based, organized, safety bundles, and we see an improvement in maternal health outcomes. So I think that easily translates. When we look at surgical issues, whether it's infections, post-op complications, you can take that same approach, a collaborative effort, creating safety bundles, and then implementation of those works very, very well.
Brilliant. I think we need to connect you with all of our partners working on health system strengthening, on surgical care. And can we steal that model and add surgery to the title? I think that's great for everyone out there. Fantastic. On a similar note, Blake, I know you're also familiar with various funding models, financing models. Do you have any additional ideas or any strategies for, how are we going to fund this issue? You've got an idea of how much it's going to cost. What do we need to do to get there?
That's the question that keeps us up at night. It's the question that we sit in a room, and I know a lot of us sort of ruminate on, and a lot of it sort of requires looking at other programmatic interventions and asking what has been successful. And I think I'd start by saying that you can think about this in terms of like immediate feasible actions and then sort of long-term ambitions. For the immediate and feasible funding mechanisms, I think we've already actually heard that the best thing that I think we can do is advocate for and support national surgical plans. In addition to having national surgical plans that are robustly costed and integrated into a national health budget and a national health plan. And so once you have a national surgical plan, you can start thinking about different ways of mobilizing domestic resources. So for one, to re-emphasize the cross-cutting nature of surgery, you could go to different programs that may already have funding and emphasize the overlap between surgery and maternal health, or surgery and injuries, and look for allocative efficiencies, such that we're not saying that it's in surgery instead of maternal health. It's not surgery instead of injury prevention. It's surgery for maternal health. It's surgery for injuries. I think we could learn from our NCD colleagues. As suggested in the Lancet Commission on Investing in Health and starting to be implemented as questions of taxation. Taxing alcohol, tobacco, sugar, and sort of finding analogous industries, which in our case might be, for example, the ammunitions industry, taxing guns, taxing bullets, that we know result in significant injuries. In terms of countries that are going to require significant capital expenditures, you might think about group purchasing agreements, either within country or among country, to increase bargaining power and drive down the cost of CT scanners, anesthesia machines. But then, you sort of face the reality of the $420 billion right in the face. And you start to think sort of more long term. And I know a lot of us enviously look at the Global Fund and the Global Financing Facility and say, you know what, for low-income countries that are going to need development assistance for health, we need a global fund for surgery. And not to belabor the mechanisms and the added efficiencies, but once you have a global financing mechanism, the innovative solutions really sort of expand dramatically. You could think about looking at what UnitAid's done with the solidarity levy on airline tickets, and again, you could go after the ammunitions industry. Similarly, I shouldn't say go after, strike it from the record. You could think about, oh my gosh, I lost my train of thought. Ammunitions. Thought about ammunitions. I may have to pass it on.
Why don't I suggest that we sit you in a corner afterwards and we'll get people to come chat with you and we can have some good ideas. These are all brilliant ideas, and I think at the G4 Alliance we often bring groups of experts together and we're really trying to solve these issues, and I think we don't have a single answer, but it's going to take a community of people to come together and figure it out, and hopefully we can continue to work with UHC partners as well to get there. And what I'll offer, I have a question for you, Dr. Sukat, but what I'll offer is if anybody else would like to chime in at any point, please go ahead and jump in, and then we'll move on to some questions from our audience. So we're looking forward to hearing from you. So Agnes, you've heard about these great perspectives from various surgery actors and stakeholders, but can you tell me, in terms of financing and in terms of partnerships, what do you view as what's needed so that we can really integrate surgery as part of the UHC platform? And I think it's been there, it's always been there, but never explicitly as surgical care, perhaps in terms of maternal health or in terms of trauma. But what can we do to really make sure that it is acknowledged, remembered, financed, and integrated? That's a big question.
Well, obviously jet lag takes a toll on brain power, but hopefully we won't need brain surgery. I think the fundamental point here can be probably summarized into two concepts. One is the one that we coined in the Lancet Commission on Investment in Health of 2013 of progressive universalism. And the other one, which we are now working on in WHO, which is the progressive realization of UHC. I think both the work that we've been doing at WHO on sort of menu of universal health coverage interventions, as well as the recently released, 13 volumes of DCP3, really give a very, very good, solid basis of what should be a full package of UHC interventions. But what it doesn't really say is the progressive realization of that in different contexts. Because no country comes from a completely clean slate, right? Countries are at different levels, they have different constraints, they have different gaps in health system delivery. So the identification of these gaps is essential, right? If I was mentioning human resources because in my view that's the most important. If you have a massive shortage of human resources, you need to outline how you're going to get from here to there. How you're going to identify the students that are going to be trained. I often use the example of Liberia, in which a couple of years ago, it was actually before Ebola, before the Ebola epidemic, there was a year in which the failure rate at the high school exam, at the end of high school, was 100%. Right? That was a couple of years ago in Liberia. So if you have this kind of difficulties in which you just have an education system that doesn't produce the kind of basic skills, both reading skills, computing skills, analytical skills. How are you going to invest in actually training health workers, let alone surgeons? Right? So I'm taking just that example because obviously it's going to be different in Liberia from what it is in Zambia, where you won't have that particular problem, or what it is in Iran, which has already a surgical workforce that is there and has a lot of universities that are training surgeons. So this kind of identification of pathways and see how you progressively build that ecosystem that you're talking about. We know that if we want quality surgery, you need to build a full ecosystem. Right? But before that, you need some basic inputs. So you need the human resources, you need the basic infrastructure. And in the low-income countries, this is what you need to invest in. And that's what I call progressive realization, is that sequencing of investments. And there is really clearly, for us, a challenge in re-evaluating how we use development aid. We actually, as WHO, we're releasing today, and I'm really encouraging you to have a look at our new report on health financing for UHC, on global health financing for UHC. And we have here very powerful evidence of fungibility. That is that you see that the external funding is crowding out the domestic funding. The external funding goes up, domestic funding goes down. External funding goes down, domestic funding goes up. In the very same countries, you have an incredible variability. Right? So that is actually a sign of lack of adaptation, lack of external funding, that is, we probably over the MDG eras have too much focused on quick wins. So if you focus on quick wins, then you will buy commodities. You will try to get quick results with the existing low equilibrium of system. So with the existing workforce, existing infrastructure, you will just try to get the bed nets, to get the vaccines, and just get the quick results. That was sort of the MDGs, like get there with the low-hanging fruits. But we just entered the SDG era. Probably we've captured most of the low-hanging fruits, and now the fruits are higher. Right? And you're not going to get it with just injecting commodities. And now, actually, the evidence we have in this report published today is that if you do that, you will probably displace domestic funding. So we really need to go back to sort of public finance 101, which is you need to look at the marginal benefits of your marginal investment. And when it comes to project financing, you need to invest in investment cost, not in recurrent cost. You need to start investing in pre-service training, in infrastructure, in institutional capacity, and let the domestic financing pick the recurrent cost. Right? So that's really, for me, what the new partnership should be.
Wonderful. Well, thank you to our panelists. What I'd love to do is to have Dr. Makasa Emmanuel share a couple of remarks. And just, Agnes, I love that. The SDGs are not the low-hanging fruit. It's the high-hanging fruit, but hopefully it will be sweeter, and we'll get there progressively.
Yes, still on financing, just a comment. We appreciate the inputs that's been given. And that's kind of specific to the country context. But we should also remember that we have to build the whole structure of delivering global surgery. WHO has to work through a certain mechanism. And we have to stop targeting specific. We can't, if we want to build this hotel, we can't build a room there, a room there. We have to build a structure first that anchors the rooms. So the room I'm talking about are country context. You want to help Botswana, you want to work Zimbabwe, you want to work Zambia. That's just building a room without the system that's going to anchor the room. So we have to think about also setting up that global, regional system that's going to ensure that what we're trying, the commitments we have made can actually be implemented. That is important, and that also needs financing. So we shouldn't only look at the financing the country context. Yes, in the country context, there is need for balancing the domestic and external funding. But we have to build that structure, that system that's going to ensure that the countries can actually deliver and go to the end. Like you said, the low-hanging fruits are not there anymore. They are higher. But to get those higher fruits, we need that system to help us to get those fruits.
Well said. Thank you so much. Again, thank you incredibly to our panelists and to all of you today. We're not quite done yet. We've got a few things that we want to do. First, we'd love to open up the floor to your questions and to your comments. And I think we have a microphone somewhere. Yeah, right here. So Emma has a microphone, and we'll open it up to the floor. Yes, right here. Thank you.
My name's Dennis Gilhooly. I'm with the Global Health Innovation Task Force, which is the successor to the United Nations Digital Health Initiative. Currently, UHC, it started off as a money issue. It's now evolving into a human rights issue, with Dr. Tedros courageously suggesting that it is a basic human right. But there's a huge gap in the discussion on UHC, and that's digital health. So I would like to ask the panel how we enshrine digital health within, and that means working with the private sector, and that means WHO has to work with the private sector, and obviously you're evolving in that direction. But with the MDGs, and I'm very glad you raised that, we waited nearly a decade, and I was right in the middle of this at the UN, before we actually engaged with the private sector. It was about 2010 before the private sector became seriously involved in the MDGs. With the SDGs, we have the opportunity to bring the private sector in at the beginning. But in the agenda tomorrow and the next day, there isn't one private sector speaker. So the two questions are, how do we enshrine digital health at the heart of UHC? And how do we actually welcome the private sector in with an incentive structure and accountability structure that is sustainable? Thank you.
Thank you. Do we have some panelists that want to Pierre, it looks like you're.
Well, you know, it's a challenging question, but I would say from our perspective that going forward in innovation in healthcare, every single innovation that we make in the medical device space and generally in pharm really has digital health integrated in, because communication is absolutely key. And there's no reason for us not to believe that that's not the same case in low resource environments as well. So I'm not sure I have an answer, but I would simply echo what you're saying, that is absolutely critical to integrate digital health and communication platforms into all of our innovation strategies.
The problem is this is not a policy priority at the moment, either for the bank or for the WHO.
Is not a policy priority to work with the private sector?
Well, to be able to work with the private sector, I mean, I know this. I mean, WHO won't even engage with Google, for example, which is crazy. You know, that's ICT. That's not pharma. It's not tobacco. But there is an inherent cultural problem in engaging with the private sector, and also moving into the technology space.
I think there's several, of course, aspects to that question, right? It's a multifaceted question. I mean, obviously, from the WHO perspective, our first responsibility is the assessment of the value of those technologies. And it's increasingly challenging because there are more and more, and there's a kind of exponential curve there, right? It used to be that WHO took 10 years to produce a guideline, right? It's quietly reviewing a particular set of interventions. It becomes more and more difficult, first because there's many more interventions coming out, and particularly around digital health, but also because, you know, today's world doesn't accept it. We're going to have to wait for 10 years. Right? There's much more demand to have sort of real-time response. So one is the challenge to really have the capacity to assess. You know, if you see, for example, digital health, all this mushrooming of apps and so on, the value of that is not that easy to assess and to actually clearly show. In the same way, when in the surgical space, there's a lot of high-cost technology that are not that easy. But we have a department who is doing that, and we try to systematically do this kind of assessment. So that's the first role. The second one is, it comes back to the point I was making before, is to sort of that dream of leapfrogging. So yes and no, right? So for sure, there are mobile phones everywhere, a lot of things that can happen with mobile phones. At the same time, if you don't have networks, if you don't have electricity, if you don't have connectivity, this is very limited. So there is, again, this question of the basic investments in infrastructure, which come back into the space of the World Bank and the plate of the World Bank, and that is really the responsibility of development banks, and we really expect there a lot to happen. And then there is the direct engagement with the private sector, and yes, there, I mean, WHO, we have very clear charters on that, very clear rules, but we are opening up, right? We create more and more platforms in which we can work with the private sector. It's just that there are really very clear norms for that. So that we can protect the independence, the transparency, integrity of WHO. But I think it's getting better, right? Maybe I'm too optimistic.
I just wanted to give a perspective about that. Thank you very much for what is a very important question. I spent my career with Kaiser Permanente, the largest health maintenance organization in the United States, 21,000 physicians, and technology is one of the most important innovations. With a fully electronic record, my patients can get an appointment with me on their cell phone. I can talk to them on my cell phone to their cell phone. We let them choose what type of appointment they want. So I think those kind of innovations are absolutely incumbent on all the changes that we're talking about.
Thank you. And just a comment from the country context. I also would like to challenge the private sector, especially on IT and information, not to wait. Countries are moving forward. They're developing their plans now. You have a role to play in ensuring that those plans can take care of those perspectives, and you can engage. And in fact, like we said, WHO has been mandated to engage. They have a framework through which they can engage. But they could be restrictive. It's a trial. We'll see how we go. But with the countries, you come and engage with us directly. All those hurdles are not there. So don't wait until we develop our plans and then say we lift you out. You have to come to the table now when we're developing these plans. You have to ensure that we can see your side of the story and your perspective. We really appreciate the contribution that you make. In fact, in demonstrating impact, and reporting back, we have to report back how far we are going and how much we're implementing every 2 years through the World Health Assembly until 2030. We won't do that without information. So you have a role to play, and I challenge you to come forth and come and sit on the table with us.
Sorry. Let me just also add in terms of digital from G's perspective, and a lot of it relates to big data in terms of how to analyze the information to improve clinical outcomes, but also efficiency within the hospital. Now, I'm not sure how this would apply in the safe surgery setting, but I do feel an important first step is to really monitor and track how this initiative is going. I think that's a first step. Will be an indicator with the World Bank. We track the progress of all the investments and good work we're doing. And again, digital for G's, again, big data and how do we use that information for clinical outcomes. So I think there needs to be further discussion in terms of how that type of tool or digital strategy would work in these markets, but certainly something to talk about more in detail. Yeah.
Thank you. Lots more to speak about. I think we have time for one more question. We'll take that one from the gentleman in the audience.
Hi. My name is Daniel Berman. I'm from Nesta, based in the UK. We heard a bit earlier, it was Abraham who mentioned the idea of what we call an AIDS task shifting. So this idea of using cadres and enabling them with new skills training. And my question to the panel is, in terms of tools and services, if you think that the people who are doing surgery like cesarean section would have a different profile than surgeons and anesthesiologists that were fully trained, I'm wondering from the panel, what do you think are the most important tools and services to actually enable those cadres that are it sounds like they're a bit like clinical officers. And the question is, in addition to digital tools and education, what other things would you say were their priorities from experiences?
Hello. Okay, I could answer a little bit of that question from our little experience. In Zambia, we actually conducted a trial, a clinical trial, to actually scientifically test the issue of using other cadres for surgical services specifically. And this was done under a study that was financed by the European Union through the Irish College under a program called Coast Africa. So we followed up, we trained clinical officers in surgical skills and assigned them to specific district hospitals as opposed to others. And then we looked over a period of 3 years, following up on the health outcomes and everything else that goes with the service delivery. For the details, of course, you can look up that, and I can give you the links. And yes, we did get good health outcomes. Yes, we proved that it's very possible to work with other cadres to actually provide the services. Yes, of course, we had to restrict what services or what skills they were actually given, because they were not given a mandate to do anything. Of course, that's not possible. So there were specific things that they could do, that they were trained to do and supervise, and they also had constant supervision even during that period of time. For challenges, which is the question that you are asking, one key thing was the issue of we're training a human being who has ambitions and needs. And while it was true that they will probably stay in the rural areas, because there's always a challenge in the developed world that most of the skilled cadres or professionals will stay in the cities, and then we don't have anybody in the rural areas. And so it was kind of possible to place these people in the rural areas, but did they have a career path? They started questioning that, because once they are trained and they're skilled, and now they want to be something else, or they don't want to stay in one. Nobody wants to stay in one place forever. That is a challenge, and it's something that you have to think about when you're setting up such a system. Even if we always do task shifting or sharing for to be a transitional process, there is still that question that arises. And all governments, or whoever is trying to do that, has to think about that. There will be questions about career paths which you have to answer. And also, there's also issues of conflict between the cadres, the lower cadres, so to say, and the doctors. Because, as you know, in the Zambian situation, once we train our doctors, because they are sponsored by government, they have to contribute back to national service. So they have what we call rural attachment. So the doctors, once they have trained and they are competent enough, we send them to the rural areas to pay back, so to say, in a 18-month program called rural attachment. But what we found out was that the doctors who are just graduated and young did not have enough surgical skills as the lower ranking officers that we had trained in their areas, and we had selected these from those who had already practiced for a while, when they were placed in the same position. And as you know, from the population, if you cannot operate, you're not a doctor. That's how the population views the healthcare workers. So if you're a doctor wearing a white coat and you can only give paracetamol and you can't do an abscess, you can't deal with a fracture, then you're not a doctor. So one, there were problems with the doctors themselves who were feeling incompetent. And then there was this clash between them and the clinical officers who were trained, because the clinical officers therefore started demanding, they wanted on-call allowance, they wanted more incentives because they're the ones actually doing the work, not the doctor. And that created conflict within our health system, which we have to deal with. So there are those management issues that you have to think about. Off my head, I can give you those two. And I think for this fora, this is enough.
Wonderful. Oh, you know, we have a burning question in the back. Do you think we have time for one more? All right, we'll take this one from the gentleman in the back. Thanks.
Hi, I'm Dr. Rohit. I'm from a tech startup called Stasis. We're based out of India. I'm jumping off the digital health question that was asked earlier. What is the WHO and UHC, or is the WHO and UHC looking at exploring innovations, low-cost innovations, as part of building these, safe surgical capabilities in lower-income countries? And by that I mean engaging with the private sector that are not the Gs and the Johnson & Johnsons.
So the short answer is yes. We do look at innovations. As I said, on an ongoing basis, we have a department that looks at health technologies and looks at medical devices and looks at different types of interventions. So this is really our bread and butter. This is what we're doing. Whenever we can have a reasonable level of certainty that these are that they do no harm, first, that there is safety, then that there is effectiveness, and third, that there is cost effectiveness, we certainly integrate innovations. What is difficult for us as WHO is to be, let's say, immediately reactive on innovations that don't have a proven track record, but that you would understand why. Yeah, we need to err on the safety and evidence base, and it's difficult for us probably to immediately absorb innovations that don't have a well proven record of effectiveness and cost effectiveness. This said, you can see that we can really accelerate the process. That was the case for the Ebola vaccine. And if you have followed the whole process of development and testing of the Ebola vaccine, we can take an accelerated track when there is really a very important life-threatening emergency.
Sorry, quickly to follow up, what is the pathway to engaging with the WHO if you're one of the innovators?
Well, there are many different pathways, right? We have many different platforms. We have many different technical groups. We can have that conversation. It really depends on what the issue is. But we constantly engage. We constantly have working groups, both in our regional offices and in headquarters, on all sorts of issues. And we also have a platform of dialogue specifically for the private sector.
Thank you. Thank you again to our panel. Can we give them a round of applause? It was dynamic, you were engaging, you shared your wisdom. I've learned a lot from all of you, and hopefully we can continue the discussion later on today and next year, that we'll be back and we'll have a clear blueprint and we'll be collecting data and we'll be able to share some progress updates. Before we get you off to your next session, I wanted to invite Dr. Key Park to join us for some closing remarks. And Dr. Park is wears many hats, but he is representing today as a consultant with the WHO Emergency and Essential Surgical Care Program and one of our hosts. He also works at the Harvard Program in Global Surgery and Social Change. He's a neurosurgeon, which is why you got some neurosurgery jokes. And I'm sure there are other things we don't know, but he was actually one of the people to help to catalyze this event. So, Dr. Park.
Thank you. Yeah, and Agnes, if you ever need brain surgery, I'll give it to you for free. Today we heard from a range of experts and world leaders that achieving UHC will need a broad expansion of surgical, obstetric, and anesthesia services where the patients are at the district hospital levels. Only then the mother in Sierra Leone, who's in imminent danger of losing her baby and maybe her life, can get a life-saving cesarean section in time. Only then a Cambodian farmer who has a hernia that's incapacitating can get the surgery he needs to get back to work and produce for his family. Only then maybe a child in Nicaragua who has a cleft palate can get it repaired and go back to school. And only then maybe a Haitian woman with a lump in her breast can get the diagnosis early enough to save her life. But to get there, we all need to work together. In integrating surgical, obstetric, and anesthesia care into health system strengthening and the UHC movement, and in convincing countries to commit politically by developing national surgical plans, and in coming up with a global mechanism to address the financing gap. I know I'm speaking for all of us when I say let's all work together to prioritize surgical, obstetrics, and anesthesia care to achieve UHC by 2030. 5 billion people are counting on us. Thank you.
Not at all.
Very nice to meet you. Yes, actually, can we get a picture?
That's what we've never seen. Some of
Remember these?
Oh,
yes.
You're gonna make me do it again?
Which color? No, I was like, I was done.
Which one goes with my?
It was the Kit Kat.
Here, everybody grab it.
What am I endorsing?
Take a group picture.